AP projection Berman method. Let patients sit at the end of the radiographic table. But we don't have radiographic table, that's why we use a table and some kind of papers to illustrate this kind of projection method. So that the forearm can be adjusted to lie approximately parallel with the long axis of IR. Part position should be placed on the image receptor under the wrist and center the first CMC joint to the center of the IR. Hyperextended the hand and have the patient hold the position with the opposite hand or with the bandage loop around the digits. Rotate the hand internally and abduct the thumb so that the flat of the IR shield the gonads. PA projection folio method. Sit patient at the end of the table with both hands extended. Position both hands side by side to center of cassette, rotated laterally into more or less 45 degrees oblique position result in true PA projection of both thumbs. Place support as needed under both wrist proximal thumb regions to prevent motion. Ensure that hands are rotated enough to thumb parallel to IR for true PA projection of both thumbs. Place round spacers such as roll of medical tape between proximal thumb regions, wrap rubber bands around distal thumbs as shown. Immediately before exposure, ask the patient to pull thumb apart firmly and hold. Note: explain the procedure carefully to the patient and to observe the patient while applying tension on the rubber band without motion before initiating exposure. Work quickly because this can be painful for patients. AP project robot method. Sit the patient parallel to the end of the table with hand and arm fully extended. Rotate arm internally until posterior aspect of thumb rests on cassette. Place thumb in center of the IR, parallel to the side border of the cassette. Extend fingers so soft tissue does not superimpose for CMC joint. Advise patient to hold fingers aside with the other hand if necessary. CR directed 15 degrees proximately toward which, entering the first CMC joint, minimum SID of 40 inches or 100 cm, culminate on four sides of the area thumb and first CMC joint. PA a hand. Patient is seated alongside the table. The affected arm is possible is flexed at 90 degrees so the arm and hand can rest on the table. The affected hand is placed palm down on the image receptor. Shoulder, elbow, and wrist should all be in the transverse plane, perpendicular to the central beam. The hand and elbow should be at shoulder height with max radius and ulna parallel. Lowering the arm makes radius cross the ulna and thus relative shortening. PA oblique lateral position. Sit the patient at the end of the table with elbow flexed about 90 degrees and hand and wrist resting on cassette palm down. Align and center hand and wrist to portion of IR that is being exposed from promoted position. Rotate wrist and hand laterally 45 degrees. For stability, place a 45 degrees support under thumb side of the hand to support hand and wrist in 45 degrees oblique position. Or Partially flex finger to arch hand so that fingertips rest lightly on cassette. AP oblique medial rotation. See the patient at the end of the table. Have the patient rest the forearm on the table in supine position. Part position. Place the image receptor under the wrist and center it at the dorsal surface of the wrist. Rotate the wrist medially, internally, until it forms a semi-supinated position of approximately 45 degrees to the IR. Shield gonads. Lateral projection extension. Patient is seated alongside the table. The affected arm, if possible, is flexed at 90 degrees so the arm and wrist can rest on the table. Abduct the humerus so that it is parallel to the image receptor. Shoulder, elbow, and wrist should all be transverse plane, perpendicular to the central beam. Wrist and elbow should be also at shoulder height, which make radius and ulna parallel. Lowering the arm makes radius across the ulna and thus relative shortening radius. Wrist AP lateral. The patient should be seated sideways at the end of the table. Place arm on the table with elbow bent. Ideally, upper arm, elbow, and forearm are all resting on the table. Rest the surface of the wrist over the image receptor from a prone position. Rotate wrist laterally approximately 45 degrees. Use a translucent support if appropriate. When the scaphoid is to be examined, ulnar deviate the wrist. Forearm AP. Patient should be seated on alongside the table. Forearm is supinated and its dorsal surface is kept in contact with the cassette with extension at the elbow joint. Both elbow joint and wrist joint are also kept in contact with the cassette. Forearm lateral. Patient is seated alongside the table. Elbow is flexed to 90 degrees and the medial aspects of the wrist, forearm, and elbow joint are placed in contact with the detector. Shoulder, elbow, and wrist should be in the same horizontal plane. Elbow AP. Patient is seated alongside the table. The fully extended arm and forearm is a supinated position are kept in contact with the table by lowering the shoulder joint to the level of the table. They all must be in the same plane as the detector. The detector is placed below the elbow joint. Elbow lateral. Patient is sitting next to the table. At 90 degrees elbow flexion, the medial border of the palm and forearm are kept in contact with the tabletop. The shoulder, elbow, and wrist are kept in the same horizontal plane. Rotate the hand so that the thumb is pointing towards the ceiling, ensuring all aspects of the arm from the wrist to the humerus are in the same plane. Radial head for position series. Flex the elbow 90 degrees, center the joint to the unmasked image receptor and place the joint in the lateral position. Make the first exposure with the hand supinated as much as possible. Shift the image receptor and make the second exposure with the hand in the lateral position, that is, with the thumb surface up. Shift the image receptor and make the third exposure with the hand pronated. Shift again the image receptor and make the fourth exposure with the hand in extreme internal rotation. That is, resting on the thumb surface. Shield gonads. The central ray should be perpendicular to the elbow joint. The radial head is projected in varying degrees of rotation. Distal humerus partial. Let the patient sit low enough to place entire humerus in the same plane. Support the elevated forearm. If possible, supinate the hand, place the IR under the elbow, and center it to the condyloid area of the humerus. Shield gonads. Central ray is perpendicular to humerus, traversing the elbow joint. Depending on the degree of flexion angle, the central ray distally into joint. Acute flexion. Forearm and humerus should be superimposed. The rotation, olecranon process, and distal humerus, soft tissue outside the olecranon process, and bony trabecular detail. Proximal forearm partial. Let the patient sit at the end of the table with the hands supinated. Let the patient sit high enough to permit the dorsal surface of the forearm to rest on the table. If this position is not possible, elevate the limb on the support. Place the IR in the vertical position, baying the upper end of the forearm, and direct the central shield gonads. The patient is sat high in the relation to the table. The patient then places the posterior aspects of the forearm on the IR. Patient may have to stand for this projection. The proximal forearm structures, including the ulna, radial tubercle, and radial head, should demonstrate little signs of distortion, with the distal humerus notably foreshortened and distorted. Scaphoid long and Rafford long method. Position of the wrist on the IR for a PA projection without moving the forearm. Turn the hand outward until the wrist is in extreme ulnar deviation. Shield the gonads. Central ray is perpendicular and with multiple cephalad angles with the hand and wrist in the same position for each projection for separate exposure and made at 0, 10, 20, 30 degrees cephalad. The central ray should directly enter the scaphoid bone. Collimation should be close to prove image quality. The following should be clearly demonstrated: that rotation of the wrist scaphoid with adjacent articular open area. Humerus lateral. The patient is preferably erect. The patient's back is against the image receptor. The affected arm is abducted and centered to the upright detector. If possible, the arm is slightly externally rotated to mimic the true anatomical position. Humerus views are often done to exclude large humeral sharp fractures or suspected symptomatic metastatic lesion. If an occult fracture is suspended at either the proximal or distal end, it is the best to do a separate elbow or shoulder series.